Welcome again and good morning to all of you. My name is Carrie McClellan. I'm the Outreach Manager for ElderHelp, and I also help to coordinate these family caregiving webinars, and I'm looking forward to today's topic, and I'll introduce our speaker in just a few minutes, but I know that it will be a good webinar for us today. So just a little bit to introduce ElderHelp to you. For those of you who aren't familiar, our organization is really focused on supporting seniors who are still living in their own homes, wanting to maintain their independence, but often are needing a little bit of assistance. And much of what we do also involves family members who are caring for their loved ones, whether they're in the same home, in the same community, or from a distance. So through COVID, our services have definitely had to change and shift so that we're able to maintain safety of our clients and our volunteers. So during the past year, we have really been focusing on the most essential services, making sure that our clients have food and essential items, as well as rides to their medical related appointments and check-in calls. So socialization has been a huge part of what we've been doing through ElderHelp to make sure that seniors in our community have access to interactions, and even if it is virtually or over the phone, making sure that those social interactions are continuing. So our family caregiver support program really offers information and referral services. We try to connect people with resources in the community and making sure that that families know what is available. We're fortunate living in San Diego. There's quite a few resources in our community, but it's just a matter of knowing about them. So we try to help with that. The webinars that we work to provide for our family caregivers in the community are much in part due to partnerships like ours with Alzheimer San Diego. And again, I'll look forward to introducing the speaker in a moment. We do also have online courses that we've created that are all free, and they're available to family members who are caring for a loved one at any stage. So whether you're just starting to think about what the future might hold, or whether you're providing day-to-day care for a loved one, those assessment tools and resources and education might be helpful to you in that process, or your family members who maybe aren't in the same area and could benefit from understanding what that role looks like. All right, so now is my favorite part, to introduce to you Amy Abrams. And Amy has worked in the field of long-term care in San Diego for 20 years in care management, dementia care, and community health education. She holds a joint Master of Social Work and Master of Public Health from San Diego State University, and is a certified positive approach to care dementia trainer. Amy is a longtime member of the Aging Life Care Association and serves on the board of directors for the National Academy of Certified Care Managers. She is a passionate educator and vocal advocate for aging and disabled adults, and currently serves as the Director of Education for Alzheimer's San Diego, a local nonprofit organization whose mission is helping families today while finding a cure for tomorrow. And it's always a pleasure to be able to introduce Amy. She shares a lot of information and does it so in the way that I think is helpful for all of us. So I look forward to learning from you again today, Amy, and the topic of Dementia 101.
Thank you so much, Carrie, for the nice welcome, for the invitation to come and be a part of this ongoing series. We at Alzheimer's San Diego are also so grateful for our partnership with the good folks at ElderHelp, and it's really terrific to get to come and talk about a very important topic, and that is dementia. So let's see if my...
Hold on, let me give you the reins, and then just to let everybody know, if you do have questions, we are happy to answer those. What you can do is use the raising of your hand feature and type those in. Because of the system, it might not allow us to see those as we go through the presentation, but certainly when Amy is finished, we'll take a look and answer any questions that have come through.
Yes, I will be more than happy to answer questions or direct you, if needed, to someone who can answer something in more detail if I'm not able to today, but I will do my best. Okay, are we all set?
Yes.
Okay, there we are. And here we go. So here is what I hope to cover in some detail, but just to acknowledge this is a big topic, the topic of dementia. There is a lot to cover. I'll do my best to get into as much detail as I can, but my goal is to give a good broad overview of the major topics and issues. So we will talk about what Alzheimer's disease is, as well as a few other related types of dementia. We'll talk about the symptoms of dementia and how they're different from normal age-related changes, which is a question that I know is frequently on a lot of people's minds. We'll talk about the risk factors and then the importance of regular screening and how to go about getting a diagnosis if you're concerned about yourself or someone that you know. Then I'll give you an overview of what to expect in the way of the progression of disease, safety issues, and some key kind of basics when it comes to symptom management, living with dementia. So, and then we'll wrap things up with resources, making sure you know where to go for extra help if you need it. And again, as Carrie mentioned, happy to take any questions that we can at the end. So I'll start just by trying to kind of clarify the puzzle of a lot of these words related to Alzheimer's disease and dementia that cause a lot of confusion. They are used interchangeably and not always correctly. So I like to start by just kind of going through some basic terminology. First, mild cognitive impairment. This is often referred to as MCI, and the technical medical term for this is minor neurocognitive disorder, although you won't hear that used too widely. Most people simply refer to this as MCI. This is it's a diagnosis, but it is not a type of dementia. It is not a pre-Alzheimer's disease. These are sort of misunderstandings that we come across a lot. MCI is a diagnosis that a person might receive if they are experiencing some changes that look more significant from normal age-related changes, but they're not severe enough that they're interfering with daily life, getting in the way of normal function. But again, they sort of show up on testing and don't look like normal age-related changes. Many people, about half of people who get a diagnosis of mild cognitive impairment will in fact go on to receive a diagnosis of dementia later. Statistically, we know that about half of people with MCI will, within about 5 years, get a diagnosis of dementia, but the other half will not. So what we think is that in those cases, in those 50% or so cases, what happened was someone detected the symptoms of what we refer to as dementia early. Right? And in other cases, the person's cognition will remain stable. So what do we mean exactly when we say dementia? Again, there's the technical medical term for this is major neurocognitive disorder, not something you'll see or hear too often. But the word dementia is often misunderstood. I think a lot of people think of dementia as something different from Alzheimer's disease. It's just a little dementia. These are sort of terms that we'll hear every now and then. So to clarify, dementia is not an actual disease. Dementia refers to a syndrome. It's the word that we use to describe a set of symptoms. So memory loss, changes in thinking, visual perception, changes to a person's problem-solving abilities, their attention. I'll go through some of the symptoms in more detail here in a moment. But dementia is the word that we use to describe this whole cluster of symptoms. It doesn't refer to any one particular medical condition. So Alzheimer's disease is a type of dementia. But there are many other types of dementia, as you'll see. So the specific type of dementia called Alzheimer's disease does account for the majority of cases of dementia. It is an irreversible and progressive form of brain disease. It is the most common type of dementia by far. And then young onset, this is terminology that we use when we see symptoms in younger people. So the opposite of young onset is what is frequently referred to as normal onset, or sometimes it's referred to as older onset. The majority of cases of dementia, in the majority of cases, we see symptoms emerge when somebody is age 65. We have a strange echo. Are you hearing that too?
I don't hear it.
My webcam is doing something funny again. Sorry about that. I'm hearing myself echoing back, so I apologize. I'll get used to it here in a minute. So young onset is what we use to describe those forms of dementia whose symptoms present themselves when a person is age 64 or younger. This is less common, about 5 to 10% or so of cases of dementia, depending on the type of dementia, are what we call a young onset variant. It does happen from time to time that we see dementia in people as young as their 30s, but that is exceptionally rare. Most forms of young onset dementia onset in the 40s, 50s, or early 60s. Okay, so before I get into Alzheimer's disease and other types of dementia, it's important to kind of take a deep breath and take a step back and remember that while the numbers of people who are living with Alzheimer's disease and dementia are in fact high, and a person's risk does increase as they age, most people don't have dementia. Most people won't develop Alzheimer's disease or another type of dementia. And there are other things that cause changes to a person's memory and thinking and cognitive function, both as we age and when we're younger as well. So I want everyone to be aware of these as well. This list that you see here is incomplete. These are just sort of the most common of the treatable, reversible or treatable causes of cognitive changes that we see. When a person is presenting with memory changes, difficulty with language or attention, what we start with is sort of looking at doing lab work, doing a good physical examination to see, is there something else going on here, something besides the possibility of Alzheimer's disease or another type of progressive and chronic form of dementia. Depression is chief among these. Depression in older adults in particular looks very similar to the memory and language changes in particular that we see in people with dementia. But it could also be an illness, right? A urinary tract infection, an early onset of a flu or a cold even. Sometimes will trigger cognitive changes, especially in older and medically frail people. Dehydration, malnutrition, a vitamin deficiency, chronic sleep deprivation or just very poor quality sleep over a long period of time will certainly cause memory and cognitive changes. Being under a lot of stress and untreated sensory loss. Specifically, I'm talking about hearing loss there. Individuals who live for long periods of time with unaddressed hearing loss will often exhibit symptoms that look very similar to dementia. So it's really important to talk about these because I think the idea of getting screened and seeking a diagnosis when a person is experiencing memory changes is daunting and frightening, and understandably so, but often there are other things at play that may fully account for the changes that you're seeing, or these conditions can coexist with early Alzheimer's disease, for example, or another form of dementia, and be making the symptoms worse. So it is important that we be aware of these possible changes. Having said all of that, most dementia is in fact caused by a progressive and irreversible form of brain disease. So Alzheimer's disease, again, accounts for somewhere between 60 and 80%, depending on what data we're looking at, of all forms of dementia. It is far and away the most common. But you see there that about 1/4 or so cases of dementia are caused by non-Alzheimer's types of dementia. There are dozens of them, and I've just listed here on this on the screen for you a few of the most common: Lewy body dementia, vascular cognitive impairment caused by often caused by strokes, a large stroke or a series of small strokes, a frontotemporal type of dementia, FTDs, the frontotemporal disorders, and there are many others. We use the term mixed dementia when a person is experiencing more than one type of dementia at the same time. That is unfortunately possible and in fact common. Many people have a mixed form of dementia. It might be Alzheimer's with the presence of Lewy body dementia, or Alzheimer's and vascular cognitive impairment, for example. Those are just two of the most common types of mixed dementia that we see. So let's talk for a moment about the specific type of dementia called Alzheimer's disease. So everyone's heard of this one. It's the one we're named after because it is the most common. It is where the most sort of research and popular science attention goes because it is impacting so many millions of Americans and millions of people worldwide, of course. So Alzheimer's disease was named for the pathologist who first identified it back at the turn of the 20th century. Dr. Alois Alzheimer was a pathologist working in a psychiatric hospital in Frankfurt, I believe, and Augusta Dieter was a patient at that hospital. She was 51 years old when she was admitted. She was followed closely. She lived another 5 or 6 years and died in 1906. Her symptoms were mysterious. She was young, right? She was 51, but she was exhibiting symptoms that at the time were consistent with what people called senility, right? Many of us have heard that term, senile, but this didn't make sense for a person who was in her early 50s. She had rapid forgetting, not recognizing familiar people, significant changes to her behavior, hallucinations, lots of behavioral disturbance. So when she died, Dr. Alzheimer requested permission to autopsy her brain, thinking that what they were seeing was not in fact due to mental illness. It was not, they weren't able in her lifetime to determine any other physical condition affecting her. He thought something is going on in her brain tissue. And sure enough, what he saw is depicted in this graphic that you see on the screen here. What he saw were these clusters, these accumulations of two kinds of protein, beta amyloid, which forms these plaques in the spaces in between the brain cells, and tau, another kind of protein that causes what are called neurofibrillary tangles inside of the neurons, inside of the nerve endings of the brain cells. So beta amyloid and tau, we now refer to as the plaques and tangles, the hallmark of Alzheimer's disease. So the syndrome, the condition, was named for him after he presented a scientific paper about his findings at a conference. So that's where that difficult word comes from, Alzheimer's. So what happens in Alzheimer's disease is still fairly mysterious. When I talk about the plaques and tangles being the hallmarks of this disease, it is important to note the research community is still trying to get a handle on that. Exactly, is it the plaques? Is it the tangles? Is it one? Is it both? Is it something else, right? Is the accumulation of these proteins due to something else that causes the brain to overproduce these proteins? There are still a lot of questions about it, but unquestionably, we do find these accumulations, these buildups of these proteins in the brains of people upon autopsy after they've passed away, the vast majority of the time, when during their lifetime they had symptoms that were consistent with this condition that we call Alzheimer's disease. It is neurodegenerative, meaning it causes brain cells to die, and therefore it causes brain tissue to atrophy, as you see demonstrated in this graphic here. Normal brain tissue is robust. You know, a healthy brain kind of looks a bit like a nice healthy cauliflower. And when the brain has been kind of ravaged by Alzheimer's disease, you see the difference. There's significantly less tissue. There's more space. We call those the ventricles. There's more cerebrospinal fluid that builds up in the spaces around that atrophied brain tissue. In particular, I want to bring to your attention, you can see that there's this region of the brain in the middle there that's significantly atrophied. That is the region of the brain where the hippocampus is. This is a small seahorse-shaped hippocampus is from the Greek for seahorse. A seahorse-shaped, very small structure in the center of our brain. We have two of them, one on in each hemisphere. Our brains are two identical hemispheres. The hippocampus is primarily involved in the creation and storage of short-term memory, and it's also right next to and very involved in our language centers as well. So as you can see, in advanced Alzheimer's disease, that part of the brain is significantly damaged. That tends to be the part of the brain where the Alzheimer's type of dementia starts. So because of that, short-term memory loss and language changes are often the earliest symptoms that we see in someone with dementia. So just a quick note to say that every type of dementia is different. Right? I won't go through them all in great detail here. I'm happy to answer questions if you have them about specific non-Alzheimer's types. Alzheimer's tends to start in that temporal lobe. The green region there is the medial temporal lobes in the centers of our brains where that hippocampus resides. Other types of dementia, frontotemporal, for example, will start in that orange region, the frontal lobes of the brain. And so it produces an entirely different set of symptoms. So each type of dementia, just as an example, each type of dementia is caused by an accumulation of a different type of protein. It spreads in different patterns in different regions of the brain, and therefore will affect the brain differently and produce a different type of symptoms. So something that is often on people's mind when it comes to dementia is, I've noticed some significant changes in my memory and my thinking and my ability to learn and problem solve as I've been getting older. Is that normal, or is that something that I should be worrying about? Or should I be worrying about changes that I'm observing in someone else? So let's just start by saying memory changes, a slowing down in one's ability to process information. These are normal age-related changes. Your brain is changing as you age, just like every other part of your body. What's different when a change sort of qualifies as a potential symptom of Alzheimer's or another type of dementia is when that change represents a couple of things: a marked change from what was normal for you. Right? So every person has different sort of cognitive strengths and abilities. I am a very verbal person, as you might have noticed. I have good language memory, but I have terrible memory for numbers, right? So you can tell me a 7-digit phone number, and by the time I can write it down or get myself to a keypad, it is gone. That is just how my memory is, right? Every person has their individual kind of baseline, the type of memory, working memory, particular cognitive abilities that are very strong and others that are weak. So a symptom of dementia for me would probably not be if 10 or 20 years from now, somebody gave me a phone number to remember and I instantly forgot it, right? We wouldn't necessarily worry about that in me because I never had a good memory for numbers, right? Whereas somebody who was very good with numbers, if that changed for them, that would be something we want to notice and sort of put up as a potential red flag. It also needs to be a change that's significant enough to interfere with your daily life. So my ability to not remember a phone number, I have developed workarounds for this. I don't need to do that in my day-to-day life. But if it were essential to my work, to my ability to engage in important recreational activities, right? If those changes represented something significantly, a significant loss of function for me, that would in fact be a red flag, a potential symptom of dementia that would be worth investigating. So the symptoms kind of fall into these 4 very general categories that I'll walk you through individually here. We'll start with memory. So normal age-related changes are, more difficulty finding words or remembering Remembering other names, nouns in particular, proper nouns in particular, are harder for us to remember as we get older. Right? Misplacing things more often. These are normal age-related changes we don't need to worry about. But what's not normal is getting lost in a familiar place, forgetting the name of a very familiar person, right? So if right now, well, actually, my name is probably somewhere on your screen, so you probably have some kind of a hint, but, we just met each other a few minutes ago. You heard my name a few minutes ago when Carrie said it, but if you couldn't see it on screen, and we were just talking 10 or 20 minutes later and you didn't remember it, this wouldn't be something to worry about because my name isn't an important detail in your life, right? Whereas if I were your longtime neighbor, who was an important source of support and friendship to you, and you forgot my name, that would represent something significant that we would worry about. Right, so getting lost in a new place, no big deal. It's harder for us to navigate and remember directions as we get older. Getting lost in a familiar neighborhood and a familiar route, that would be something to worry about. Losing your keys, losing your glasses, losing your phone, right? We're going to do more of that as we get older, and it's nothing to worry about. But when you've actually forgotten the function of an object, you're holding the keys and don't recognize them as the things that are going to get you inside the house or to get the car started, that's when we worry about that. Thinking, this is just sort of a catch-all term that we use for a variety of kind of non-memory cognitive tasks. Our thinking certainly changes as we age. We are slower to learn how to do new things. We're slower at solving problems. Right? Anybody that's in midlife learning to speak a new language or play a new sport or a game or a musical instrument, right? You know what I'm talking about. You still can, right? If your brain is healthy, you'll continue to be able to learn new skills and develop and grow until the very end of your life, but you will be slower at it starting in midlife than you were as a younger adult. It's just a simple matter of changes to our brain kind of neuroplasticity. It's just a reality of the human brain. And in addition, difficulty with sort of paying attention and focusing one's concentration. These are normal age-related changes, right? When you're driving a car, now you probably have to, like me, sort of turn down the radio, ask people in the car not to talk to you, right? If you're lost and you're trying to figure out where you are, right? Those types of changes are totally normal and nothing to worry about. But when we start to see new difficulties with things that used to be familiar and easy, language, reading, writing, working with numbers, doing calculations that used to be easy, for example, that would be something to worry about. Being more slow at learning new things is nothing to worry about, but being unable to learn new things is potentially a problem, right? Maybe an indication of damage in that hippocampus. Additionally, if we see changes to the way people just generally kind of think things through, reason through a solution, apply judgment or reason or insight to a problem, if they're starting to just make decisions differently than they used to, more impulsively, for example, or maybe they always were a very impulsive person and now they're really struggling to make any decisions at all, right? So you see the pattern here that I'm describing. If it's a noticeable, marked difference that gets in the way of normal function and it's new and different for the individual person, it's something for us to be aware of. Physical changes, of course, are a part of life. They're a part of aging, and changes to our vision, our hearing, our sense of smell, other sensory loss. These are normal and to be expected. There are things we can do to mitigate them and improve them, as with losing some muscle strength, losing some flexibility. These are normal age-related changes that we can, again, we can address and we can prevent them to a certain extent, but they're normal and nothing for us to be alarmed about. However, it is important to know there are physical symptoms of dementia as well. One of them notably is a significant narrowing of the field of vision. So people, even with very early dementia, can start to experience a dramatic narrowing of their field of vision, their periphery. And that is not a normal part of aging. We'll experience some of that, to a certain extent as we get older, but it can be really quite dramatic in people with dementia. As well as difficulty with other types of sensory processing. So it's your ears, of course, the structure in your ears that allow you to hear things, but it's your brain that tells you what you're hearing and what, when you smell that smell, oh, that's smoke, I need to get out of this room, or you hear that sound, oh, that's a siren, I need to pull my car over to the right side of the roadway, right? It's your brain that tells you what it is that your sensory organs are taking in and what you should do with that. And when there's difficulty with that, that is potentially a red flag. Additionally, we'll see more challenges, more difficulty with balance and concentration, and therefore coordination, and therefore more frequent falls are common in the early kind of sometimes preclinical stage of dementia. We'll notice that people's balance is changing, their gait. We may see changes to, a new shuffle or sort of a new stoop in their gait that they didn't have before. All of these things, of course, I again need to kind of step back and pause, and we need to remember there are other medical conditions, stress, other temporary things that might be going on that account for any one of these symptoms or more. I'm wanting to point out those things that ought to give us pause, that are different from normal age-related changes and that we want to bring to the doctor's attention. Behavior is the final category of the possible symptoms of dementia, and it's important to talk about because our personalities, our overall kind of demeanor and behavior, the way we act, the things we say, the things we do. For better or for worse, it doesn't generally change as we age just because we're aging. Maybe because we've made a conscious decision to try to change our behavior, or because we're experiencing something like stress or grief or a mood disorder, right? Anxiety or depression. These things will produce changes in a person's personality and behavior. But outside of those things, generally we remain fairly stable and consistent throughout our lifetime, and for better or for worse. But when a person has dementia, we frequently see changes to their personality. They're not always negative, by the way. I mean, a person could become much more easygoing if they were kind of an uptight, difficult personality. It's just, again, a change from what was normal for them. Often what we'll see is withdrawal from activities and people that the person used to enjoy, or maybe difficulty starting new tasks, getting things going, or even the reverse of that sometimes, having a hard time stopping once you have started a task. All in all, we're talking about just the changes in how a person normally acted, changes in their routines, changes in their sort of usual preferences and abilities. So I hope that clarifies the differences between normal and not normal. But again, if you've got questions about any of those, I'm happy to answer them. Those, by the way, are just the most common of the symptoms that we see in Alzheimer's and the other kind of major types of dementia, but there are other symptoms as well. So who is at risk of ADRD? Sorry for that shorthand there. That's Alzheimer's disease and related dementias. All of us. Age is the primary risk factor, and so the older we get, the greater our risk of developing Alzheimer's and other types of dementia. 1 in 9 people over age 65 in the US today is living with some form of dementia. And by the age of 85, we have about a 1 in 3 chance. About 40% of people over age 85 are impacted by one or more types of dementia. Those are big numbers. But again, I like to point out there's still the other 60% that aren't, right? But certainly these are risks that we all need to be aware of and mindful of. Sex is another risk factor. Women are at higher risk of most types of dementia, including Alzheimer's disease. But there are some frontotemporal dementias and vascular dementias, for example, are conditions that men are at higher risk for. Health factors, including hypertension, heart disease, type 2 diabetes, and again, that untreated hearing loss. These are considered risk factors. None of these are causal, with one exception here. Having diabetes, for example, doesn't mean you're going to develop Alzheimer's disease, but it does put you in a higher risk category. So if you have these conditions or you inherited risk factors for these conditions, then you're generally considered a higher personal risk. Your genetics and your family history do play a role, but it's a small role. There are only a few very rare forms of dementia that are truly inheritable, meaning you got a particular genetic mutation that caused the Alzheimer's disease. Those are few and far between. They tend to be young onset, very young onset forms of the disease. There are some genes we've identified that and you can find out, through services like 23andMe, for example, whether or not you're considered higher or lower risk, depending upon your particular genetic profile. But they are just risk genes. They don't tell us whether or not a person is going to or is going to be protected from developing Alzheimer's and other forms of dementia. Having said all of that, your family history is relevant. If you have a parent, have or had a parent or a sibling, a first-degree relative with dementia, then you are considered higher risk of developing that particular type of dementia. But again, in most cases, even if generations of women in my family, for example, have had Alzheimer's disease because my grandmother had it, my mother had it, that does not mean necessarily that I'm going to get it. But does it increase my risk? Absolutely. Your education level is a negative risk factor. The more formal education a person has, the lower their risk of developing dementia. So keep learning. That doesn't mean degrees. It just means the number of years that a person engages in sort of purposeful, intentional learning. And that we can do at any age. Head trauma is the one exception here in that there are now some pretty clearly established associations between head trauma that results in concussion and the onset of a particular type of dementia called chronic traumatic encephalopathy, CTE. You see this less so in the news these days than we were a while back, but professional athletes, soccer players, football players, hockey players, boxers, as well as veterans who sustained head trauma in combat, these individuals are at much higher risk of developing not only CTE, but other types of dementia as well. Not to say that head trauma is a direct sort of cause. If you get a concussion, that doesn't mean you're going to develop that particular type of dementia, but there is a very strong association there. And finally, the last of the known risk factors for Alzheimer's disease in particular, that type of dementia, is Down syndrome. Individuals with Down syndrome have 3 copies of the 21st chromosome, and on that chromosome resides a marker that causes the brain to produce beta amyloid, one of the proteins associated with Alzheimer's disease. So nearly every person with Down syndrome has at least 2 copies of that particular marker. Their brain overproduces beta amyloid, or the plaques of Alzheimer's disease. And by midlife, 40s or early 50s, nearly every person with Down syndrome has the pathology. They have the plaque buildup of Alzheimer's disease in their brain, and many people, the majority of people, will exhibit symptoms as well. Couple of things to note: there are significant ethnic disparities in the United States when it comes to Alzheimer's disease in particular, but also vascular cognitive impairment, those 2 types of dementia. We do see much higher rates in Black Americans as well as the Latinx population here in the United States. There's nothing genetic or racial about that. What that's about is these other health factors that were described before: hypertension, heart disease, diabetes, untreated hearing loss. These other conditions, because of disparate access to healthcare, those communities tend to have higher rates of those conditions that then lead to higher risk of developing dementia. I also like to point out that on this list there are, as you can see, there are no known environmental causes of Alzheimer's or other types of dementia. No chemical exposure, something we're eating, drinking, something in the food, water, air supply that is causing these conditions. At least not that has yet been clearly established in the research. So, for all of the reasons I was describing at the beginning, all of the many reasons that the many causes that could be contributing to changes in someone's memory and thinking as they're getting older, the way that we qualify the symptoms as being, different from what's baseline and normal for you as an individual person, these are the reasons that regular screening is so important. You have to know what baseline was for you in order to know when it changes, right? It also allows someone else to be able to detect changes. This is one of the great conundrums, the great difficulties of these conditions, is that often if I'm the person living with memory loss or changes in my personality, I'm the last one to know it, right? Everyone around me can see it, but I don't have the ability, I don't have the insight to see that because of the nature of the changes in my brain. So if you're getting screened on a regular basis, you don't have to be able to see it. The test will reveal that. Right. So it's not yet something that is sort of required and generally recommended in the same way that, for example, prostate exams, colonoscopies, mammograms, other types of screening that there are very clearly established standards for. We don't have this yet for memory screening, but we advocate strongly for everybody over age 65 to request an annual memory screening as a part of your regular physical exam, your wellness visit. It is in fact covered by Medicare. Medicare has a billing code for this, but you usually have to ask for it, and sometimes it takes you educating your doctor about that reality. Outside of the current situation wherein we have the pandemic and many resources for community memory screenings are not available, you can get memory screening through your primary care provider, but often you can go to community providers as well, including us at Alzheimer's San Diego. We do offer free community memory screening every month when our offices are open, which they currently are not. But for now, please, we'd refer you to your primary care provider, or you can reach out to us. We can connect you to other sort of resources that are out there in the community. So it allows us to identify changes early, rule out those potentially contributing reversible causes, those things like thyroid problems, a vitamin deficiency, an undiagnosed depression, for example, to treat those things and see if that in fact doesn't improve improve the challenges that the person is experiencing. So once a person is screened, then what? If in fact there are some problems that come up in the screening, it's really important that we not sort of hide our head in the sand. I can't tell you the number of people who have said to me, well, Amy, if it's Alzheimer's disease, if there's no cure, if there's no treatment, why would I want to know? Right? I'm not even interested in finding out. But there really is every reason to find out early, and to find out as accurately as you can exactly what type of dementia is this. While it is true there is no cure for Alzheimer's disease or any of these other progressive forms of dementia, we do have forms of symptom management. We have symptom treatment, which I'll talk with you about here. These forms of treatment, the medications that are available, they're generally only useful if they're started in the early stages of the disease, when the chemical changes to the brain have not yet become so dramatic that the medications can't kind of make an impact. So it allows doctors to target treatment, to give the right kind of medication at the right time, to hopefully sort of delay the progression of the symptoms for as long as possible. If you get that diagnosis, it gives you time to have those important conversations, get documents updated, participate in research if you're interested in that. When you have early dementia, you do not lose your decision-making capacity right away. You don't, contrary to popular belief, you don't get your driver's license pulled automatically just because you have a diagnosis of Alzheimer's disease. does get reported to DMV, and that's a whole issue, and we can talk about that if anyone's got questions. But it's not an automatic. You no longer can update documents, can buy and sell things, drive cars, right? For the most part, if we catch these conditions early, you're going to have a good long time living in the early stage of the disease, where you can still be pretty independent. So getting a diagnosis is not easy. The primary care provider is the place to start because they know you best. They can administer these screenings and the basic diagnostic tools as long as they've been trained in it. But they may very well refer you out to a specialist, a neurologist, a specialist in the brain, of course, a geriatric psychiatrist, a behavioral health physician who specializes in working with older adults. They're often involved in diagnosis and treatment of various forms of dementia because they mimic so closely the symptoms of dementia, and they also tend to coexist. Depression and dementia coexist very commonly. Neuropsychiatrists and neuropsychologists are specialists who generally are involved in diagnostic testing for various types of dementia. And geriatricians are terrific if you can find one. We have a real shortage of geriatricians in San Diego and elsewhere in the country. But these are internal medicine physicians, family medicine doctors who specialize in working with older people. So what they're going to do is a comprehensive medical history, a good physical, doing basic lab work, because they're trying to rule out all those treatable and reversible conditions that might be contributing to the cognitive changes first. Then they're going to do, of course, a neurological exam. This could be verbal, paper and pencil testing. It could be reflex testing. It could be visual field testing, lots of different forms that this can take. If there's concern that, yes, we think this is dementia, but we're really struggling to figure out what kind, they may refer you out to more detailed neuropsychological testing, which is just basically more in-depth battery of testing to try to get at exactly what types of memory, what types of cognition are really being affected here that can help them kind of narrow it down. Brain imaging is often ordered to have a look at kind of the structure of the brain. Do we see those characteristic changes in the volume and the shape and the function? The use of glucose, for example, in different regions of the brain might indicate, based on where we see changes, this looks like this particular type of dementia. But it is important to note that we don't currently have a widely available, accessible way to see the presence of those plaques and tangles that are characteristic of Alzheimer's disease in the brain tissue of living people. The technology exists that allows us to see amyloid in a PET scan, but it's very expensive technology. It's not available, not covered by Medicare, and so it's usually only used in sort of research settings. So we do our best, and physicians are generally pretty accurate in their diagnosis. It gets confirmed, of course, later when we're able to look at the brain tissue. Afterward, we see a confirmation right upon autopsy that, yes, in fact, this person did have Alzheimer's disease. They are accurate most of the time, but it's a challenging, difficult process to be sure. And we're working on protocols to try to sort of standardize the way that this happens for people, but it's still complicated and a big challenge. A very important part of the diagnostic workup is talking to other people. Because again, I, as the person who's experiencing the memory loss, the changes, I may not be able to accurately self-report what's going on with me. I need another, what's called a knowledgeable informant, someone who knows me, someone who knows what was normal for me, to be able to describe the changes that have been happening over time. The progression of the disease is typically long, slow, steady decline of function over time. We can't predict exactly how long the disease will be for any individual person. 2 to 20 years is generally what we predict, and that's kind of a useless set of numbers because there's such a wide span there. So it's highly variable, as are what symptoms the person will experience and how severe they will be. But there is, generally speaking, an early stage when symptoms are mild, a middle stage when symptoms are more moderate, and a late stage when they're severe. The late stage does tend to be the shortest, chronologically speaking, the shortest part of the disease, but early and mid, and that's not always the case, but typically middle tends to be the longest. But as we're getting better at diagnosing these conditions earlier, we're seeing the length of time that people are in the early stage kind of lengthen a bit. Here you see the 5 FDA-approved medications for Alzheimer's disease that are also sometimes used in other types of dementia as well. These are not what are called disease-modifying drugs. They don't eliminate the plaques and tangles, for example, but what they do for a percentage of people who take them, about half or so, will see an impact. What they do is they delay the progression of symptoms. Actually, I'll go back if I can here. What they'll do is they'll sort of stretch out this line at the beginning of this progression and delay the decline that we'll see later in the disease. Basically, these diseases make the early stage, when symptoms are mild, longer. Again, only if they are started early on in the disease process. So we've got 2 primary categories of these drugs, the cholinesterase inhibitors. Aricept is the most commonly prescribed of them, but there are 2 others, Exelon and Razidine. The cholinesterase inhibitors and then the glutamate regulator, the brand name of that is Namenda. They are different classes of drugs, and so they can be taken together. And because they often are, there is now a combination medication. The brand name is Namzaric. These are, it's nothing different. It's just a combination of donepezil and memantine in one pill. So again, these are not magic bullets. They do have, of course, side effects. A percentage of people will experience GI-related side effects. But for many people, they are successful at slowing down or kind of delaying, moving out that eventual progression of the symptoms. And it's the best that we have for now. Very hopeful. We see very promising drugs in the pipeline. There is a disease-modifying drug that is set to go before the FDA for approval in just a couple of months. So we're very hopeful. That is a drug that looks like it actually clears plaques from the brain. That would be an incredible breakthrough. It's been many years since we've had a new Alzheimer's drug come on market. In the meantime, what we do is we support people in living well with the disease. While we don't yet have treatment, we don't yet have a cure, we know a lot about how to support people through this journey, the person living with the disease, and of course, their care partners, everyone around them. So we do that by meeting physical needs, emotional needs, making changes to the person's environment to reduce the number of obstacles, the challenges that they experience every day. We teach care partners communication techniques, ways of talking and connecting, avoiding the natural impulse to correct someone when they are disoriented or confused, confronting people, getting into arguments whether or not you mean to. Very, very common when you're living with or just communicating with somebody who's got dementia. Right? They're saying things that are factually incorrect. They're disoriented. They're confused. It is a natural impulse to try to address that and change it. And as I probably don't need to tell any of you who've tried it, it doesn't usually work. But we can teach caregivers, and we do. This is what I spend most of my time doing, is teaching caregivers how to change the way that they communicate, to listen not so much to the words and the facts, but to listen for emotions and validate the person's feelings, right? If what they're feeling right now is that, they need to go home, wherever they are right now is not comfortable. They don't feel like this is a familiar place where they want to be anymore. Right? In that moment, it isn't helpful to try to convince the person you are home. This is where you live, right? Instead, we learn to listen to what they're really saying, right? What they're really saying is, I'm not comfortable here, and learning how to validate that feeling, right? Of course, I understand you want to go home. Right? Learning to say things that just affirm what the person is feeling instead of arguing with them, and then eventually being able to kind of redirect their attention to something else. This can all be learned. It takes lots of practice, and nobody does it perfectly, but it does take some kind of training and skill building, right? Learning how to kind of scale down your expectations and learning to be more flexible. And then, of course, learning to address the needs of oneself as a care partner, right? Having the energy and support that you need. It takes, you can't do it by yourself, right? So I've provided here for you just a couple of examples of some of the credible sources that are out there for disease information about Alzheimer's and other types of dementia. Of course, we're on that list. Alzheimer's San Diego, our website is alzsd.org, and we maintain a pretty robust library of information about Alzheimer's disease and other types of dementia. But here you see a list of several other organizations that have authoritative, credible, objective sources of information. No one is going to be trying to sell you anything on any of these websites, and that's really important, right? There's a lot of kind of junk information out there on all sorts of topics, but in particular when it comes to Alzheimer's disease. So just for kind of general familiarity, some things we want to make sure that people are thinking about for the future. Dementia is progressive. Unfortunately, at the moment, it doesn't get better. We don't have a way to stop the progression. It is important that we be thinking about things to come, safety issues that may come up down the road, and putting support in place to address them now. So I won't go into detail on these things. I just want to bring them to your attention and make sure that you know that there is a lot of support out there around all of these safety issues, preventing falls, keeping people safe around the house from injuries and accidental medication error, preventing elder and dependent adult abuse, issues around driving and the use of firearms, big public health safety concerns for people with dementia. Of course, caregiver stress, an important safety concern for everyone, and wandering, which is a very high risk behavior in people with dementia, getting lost, right? Going in search of someone or something. So we just want for now for people to be aware this is going to be a long journey, right? It's physically, emotionally, and certainly financially draining to be living with this condition or to be supporting somebody who's living with one of these conditions. But we're here. These resources are out there between us and ElderHelp and many other terrific local nonprofit organizations. We're here to provide support, education, that skill development that I was talking about, help you build your support network, find a support group if you need one, access respite, opportunities to get a break, maybe one of the most important resources we can connect you to, making sure that you've got time to get to your own dentist appointments and doctor's appointments and take a walk and prepare a healthy meal and get a good night's sleep every now and then, right? And above all else, one of the most important tips I can give you is just do what you can to maintain a sense of humor about this. There are going to be some absurd moments, and it's okay to laugh at ourselves. It's okay to laugh with each other, and to find support for the journey along the way. So it's never too early to start thinking and talking and planning about all of these topics, whether dementia affects your life or not, right? Getting your advanced healthcare directives in place or updated, looking at the home environment. Is it safe? Is it going to work long term? Having conversations about driving and transportation, thinking about the costs of long-term care and what benefits or private resources are available to support you with that. Figuring out who you've got in your life to be part of your support system, or building one if you don't have one. And then, of course, staying healthy. These are all of the things that we exist to help with at Alzheimer's San Diego. We're a local nonprofit. We're not part of any larger national organization. We're here in San Diego County, and we exist to serve people here in San Diego County, or those who care for someone who's here. Of course, a lot of our services, all of our services at the moment are virtual, so you don't have to be in San Diego County to access them, and that's great. You can talk to one of our social workers, attend a support group, come to our classes and workshops, access our volunteer services in the forms of companion visits or daily or regular telephone check-in calls, our Vitals Volunteers in Touch program, counseling services for care partners, free social activities. We're doing online activities as well as some physically distant in-person activities. There's so much support that's available through Alzheimer's San Diego. I can't encourage you enough to just reach out. Even if you don't know what you need, you just have early questions and you want to get familiar, we are here to help, so don't hesitate. I believe that's it. I'm not mistaken. Yeah, that's the end of my slide deck here anyway. Carrie, are there any questions that have come in?
Let me see, and just thank you so much, Amy. I feel like, I always learn something from you. Even if I've heard a topic before, I think it's always helpful to listen to it again and to, you kind of take in different things at different times. So
yeah,
I hope
absolutely.
Others will continue to stay engaged and seek out further education as well. So let me go to the questions. And so one of the first questions is asking if the webinar is recorded. And yes, we have been recording. So what I will do is send it to each of you so that you can share it. It will be a YouTube link that you can share with other family members who you would like to have that education as well. Let's see, the next question is, what is your advice about sharing this with your parent that you might be concerned about? How would you approach that?
Oh, this is such a good question, and I'm glad you asked it. I mean, of course, every person and every family dynamic is unique and different. So there are some personal considerations to take into account. And first, I'll just say, if you want, you can always call our office and have a social worker kind of talk you through your situation and give you some advice on broaching the subject with someone. But speaking very generally, I absolutely am in favor of talking about it as openly and as early and as honestly and directly as is possible. There's a lot of stigma around memory loss, and there really ought not to be, right? We hope that in the years to come, we'll be able to talk about Alzheimer's and other types of dementia in the same way that we can now talk about cancer in ways that we couldn't, a generation ago. So saying to someone, I've noticed some changes. I went to this talk, or I have this material. You can find lots of good written information you can print up and bring to a conversation. I found some information about the various things that might be causing this. I think using that, using the fact that so many memory problems have nothing to do with something scary like Alzheimer's disease, right? There's many things that might be contributing to the changes that I've noticed. Why don't we talk with your doctor about, a workup, just so we can see what might be going on here. I would also frame it in the we, right? Let's go get our memory tested. If you're getting somebody to the primary care doctor, that's a little harder to pull off. That was one of the beautiful things about our memory screening program when it was available. If you're worried about your parent, you can say, you know what, I know this place that will test our memory. Let's go get our memory checked out, right? So it feels like something we're doing together. I'm not scared to get my memory checked. Let's get our memory checked together. So bringing them in and trying to just sort of demystify it, make the experiences minimally scary as you can. Don't say, I think you might have Alzheimer's disease or dementia. There's nothing wrong with the words. We want people to talk openly about it, but that will often keep people from seeking information. So keeping it kind of broad at first, that'd be my very general advice.
Thank you, Amy. I think those are very good tips. Another question came in about referring them to a specialist. And I think through Alzheimer's San Diego, you would be able to kind of identify what they're looking for and perhaps have recommendations or guide people through that.
Yeah, absolutely. So, as with all things, any particular specialist, who you can see and not see depends on your insurance and what system you're in. But we do maintain lists here at Alzheimer's San Diego. We keep them current of neurologists, geriatric psychiatrists, diagnostic clinics, for example. If you're in need of a specialist, we can provide you with a list of local providers. Absolutely.
Wonderful. Thank you. And I don't see any other questions, just more comments. Appreciative of the information. It was really helpful, and thank you so much. So that's
Great.
good. I think that there's a lot of people.
Uh-oh. I think I lost you there.
Who
Carrie, I can't hear you. I don't know if you can hear me, but
yeah.
Okay, there's a little sound. Your audio cut out there for a bit.
Oh, sorry about that. So a question is coming in about having your direct contact information. So I don't know if that's something that you are.
Sure. Do I have a way to message out in the chat? I'm happy to do that. I don't think I can. Yeah, I'm happy to provide it. What's the best way for me to do that?
So maybe what I can do is I'll send that to this person especially with
Sure.
the recording so that they have it, if that's okay.
That sounds great. Yeah, absolutely.
Okay. Wonderful. Any other questions? It doesn't look like it, so I think we will close it out for today. But again, thank you so much, Amy, for sharing your expertise with us today. And again, I will send a recording to everyone so that you're able to share it with anybody who wasn't able to make it today in your life. So thank you, and everybody stay safe and be well out there.
Yes, please. Thank you so much. Have a great afternoon.